Thank you, Dr. Rajiv, for the introduction, and I am thankful to the MP State Ophthalmic Society and the chairperson on the dais for giving me these opportunities. I have been asked to speak on tiny eyes, big challenges, cataract surgery in pediatric patients. Indeed, a cataract surgery in pediatric patient is a challenge. It is different from what we do it in adult cases. They are congenital, they could be congenital or developmental or traumatic, and so management is different because the childhood cataract not only reduce the vision but also interfere with the normal visual development. Unlike the adult onset cataract, the stimulus deprivation amblyopia which is associated with it. So important considerations are the timing of the surgery, whether we have to do the surgery or not, what type of surgery, whether lens has to be implanted, and to plan a staged or a single comprehensive surgery to implant IOL, or we can rehabilitate by contact lens or spectacles. And post-op visual axis opacification is another important aspect which has to be taken into consideration. Stability of the IOL presence and the high chance of decentration because of the excessive fibrosis. There is a pronounced inflammatory response to the surgical insult due to the cataract surgery. Post-operative amblyopia management should also be kept in mind in all these patients after the surgery. So, in patients with small central lens opacity, not significantly impairing red reflex, we can go for a medical management. We may dilate ask the patient to keep put him on dilating drops. But if the vision improves 618, then no surgery is required. And in associated corneal opacity, like in the case of Peters anomaly, where there is a central corneal opacity associated with central lenticular opacity and the nearly clear peripheral lens and cornea, optical iridotomy is the better option in such cases than the corneal transplant and cataract surgery. So when to operate? In bilateral dense cataract cases, early surgery at 4 to 6 weeks of age, and in bilateral partial cataracts, they may not require surgery or require surgery at the later age. Unilateral dense cataract, urgent surgery is required within days, and we should have a good anesthesia team to support us. Aggressive anti-amblyopia therapy should be followed after the surgery. Otherwise, if 4 weeks are passed, the nystagmus will set in and the dense amblyopia will set in a unilateral dense cataract cases. Although in most of the cases the results are often poor, after 16 weeks of age due to dense amblyopia, surgery is inadvisable in a small cataract. Partial unilateral cataract may be treated non-surgically. The management part is difficult because and we have to do a complete thorough examination. Along with it, we should take the history in detail, uncorrected and best corrected visual acuity if it is possible, pupillary reaction, IOP, slit lamp examination, fundus, B scan, and biometry should be done for both eyes, and we will be dealing in next slides. Retinoscopy, cover test, early photographs, and we should rule out the presence of retinoblastoma or the posterior segment pathologies. Various tests are pathological tests are done for each disease which are associated with the congenital cataract like galactosemia, rubella, syphilis, Wilson's disease, etc. Coming to the IOL implantation, this provides a permanent correction, and this is the choice, and most of us we do the IOL implantation in majority of our patient. But coming to the IOL power calculation, which is the most difficult part in pediatric eyes, and because they are not the miniaturized adult eyes. The pediatric eyes are different because the cornea is steep, the lens is having the high power at the birth, and it may be from 34.4 diopters at birth to, and it reduces to 18.8 diopters at the maturity after 6 to 8 years, and this is the study results which I am sharing with you. And axial length increases from 16.8 to 23.6 millimeter. So even at the neonatal age, no, the slides are not moving further. इधर स्लाइड्स नहीं आ रही, इधर तो हो रहा है. So the eye varies so much from 16.8 to 23.6 millimeter axial length, and power decreases from 34, 35 to 18, 19 diopters, and the corneal steepness also cornea also flattens, but the refraction changes from plus zero point 0.4 diopters to 0.5 minus 0.5 diopters. This is the beauty of the nature. So numerous studies have found that IL formulas for adult cataract surgery are less accurate in children because of all these changes, and we should go for the newer generation formulas, but still the residual refractive error will be too high in all these cases. Our goal is to undercorrect as myopia increases rapidly in pediatric age group, and younger the age, more is the undercorrection. In unilateral cases, greater undercorrection can lead to major anisometropia, and it is difficult to correct the amblyopia, so that has to be kept in mind. So pediatric biometry should be done, and I follow this rule of 7, that you decrease from 7 you decrease the age of the patient. If the age of the patient is 2 years, 7 minus 2, so you undercorrect by 5 diopters. So this is what I do, and other things are the Dahan's formula: 20% undercorrection below 2 years and 10% from 2 to 8 years. And the IL power assumed as per the axial length also is suggested, but I am following the rule of 7. Some surgeons choose emetropia or myopia to help in the early management of amblyopia, but I undercorrect. This is a pediatric cataract surgery, which is slightly different from the adult cataract, and because the anterior capsule is more elastic, so there is a high tendency to extension of the capsular axis to the periphery. Secondly, we have to fill, to prevent it, we have to fill the chamber with viscoelastic, and the viscode is much better, or as Dr. Khoker says, that we should use the heel-on to do this cataract. So lens matter is very soft, so bilateral irrigation or coaxial irrigation aspiration can be done, and primary posterior capsular axis I do in all cases in pediatric age group in our setup, because in our country these patients, they don't come up for the follow-up. So even at 8 years, 9 years of age, although it is recommended to be done below 6 years of age, and vitrectomy should be done from up to 4 years of age. This is primary posterior capsule, and 360-degree overlap of the anterior capsule, as you can see it is here. It should be there in the IOL, otherwise decentration of the IOL is there. Another case, just a last case, and then we'll conclude with the permission of chair. And similar, I make a sclerocorneal section, as you have seen here. So this gives me extra leverage, and I don't have to put sutures unless the child is 1 or 1.5 years of age, and this gives me the tight wound, and the removal of post-operative removal of suture is avoided. So this case, the nucleus was dense, so we have removed it with the phaco, and at epinucleus mode. The ballooning of conjunctiva occurs because of we used phaco, otherwise we don't use phaco in such cases in sclerocorneal tunnel. Hydrophobic lens is suggested in all these cases, hydrophobic acrylic lens, and I don't use hydrophilic lens, and should be avoided in pediatric age group patients. And now I do with the vitrector, I am doing a posterior capsulotomy, and we can do at the same time we can do anterior vitrectomy also. So with this, there are different challenging cases also. So traumatic cataract, I thank you for your patient hearing.
Thank you, Dr. Purin. The real challenge with these kind of the cases is to prevent the development of amblyopia. If it has developed, I mean the approach is different, and while if it has not, but the challenges are different. Thank you, Dr. Puren.